Welcome, future colleagues, to this explainer on primary mitochondrial myopathy. Let's just jump right in, because honestly, I am so excited to guide you through this. It's an absolutely fascinating, high-yield topic that forces you to be fluent in genetics, biochemistry, neurology, and histopathology, literally all at once. Examiners absolutely love testing this because it truly separates the rote memorizers from the folks who really understand the underlying science. By the end of our time together today, you're going to be able to spot the exact differences between these really complex syndromes from like just a two-line clinical stem. It's going to be a real game changer.
Okay, let's take a quick look at our roadmap. We've got 5 main stops: genetics of mitochondrial disease, biopsies and biomarkers, the core clinical syndromes, management and pharmacology traps, and finally, high-yield exam takeaways. All right, moving right along to Section 1, genetics of mitochondrial disease. So we're going to start way down at the micro level, looking at how defective oxidative phosphorylation actually arises from mutations in either mitochondrial DNA or nuclear genes. This dual genetic origin, it's a frequently tested concept right out of the gate. And it brings us to heteroplasmy. Think of this as a single cell containing a mixed bag, a mixture of mutant and wild-type mitochondrial DNA. Because mitochondrial DNA is transmitted maternally, an affected mother passes the mutation to her kids. But because of this heteroplasmy, each child inherits a drastically different proportion of mutant versus wild-type DNA. It's pretty wild. The sheer mixture inside a single cell dictates everything. Building on that idea of heteroplasmy, the exact proportion of that mutant DNA really matters, and that's because of the threshold effect. Think about tissues with the highest energy demand. We're talking your skeletal muscle, the brain, the cardiac conduction system, the retina. These are affected preferentially once a specific threshold of mutant DNA is crossed. Tissues with a lower mutant load? Well, they just remain completely clinically silent. It's almost like flipping a switch. And that single concept explains exactly why one sibling might be severely affected while another is just an asymptomatic carrier. Okay, listen up, because here is a massive exam trap. You are definitely going to be tempted to look for maternal inheritance in every single vignette. But wait, Kern-Serre syndrome, or KSS, is usually caused by a sporadic, de novo, large single mitochondrial DNA deletion. So if a clinical stem explicitly states there is no family history, do not try to force a maternal inheritance pattern onto it. Seriously, examiners love to bait you with this, so don't fall for it. Let's move into Section 2, biopsies and biomarkers. Zooming out from the DNA to the tissue level, let's examine the histological and biochemical markers that build our diagnostic framework. Now, here's a crucial point. While modified Gomori trichrome stains show these beautifully classic ragged red fibers, they are really just a nonspecific marker of mitochondrial proliferation. You're going to see them across multiple syndromes: MELIS, MRF, KSS, you name it. Students so often treat ragged red fibers as this pathognomonic slam dunk for one specific disease, but they just aren't. Getting the specific diagnosis always requires combining the clinical syndrome with genetic confirmation. Now, for a classic biochemistry discriminator, if a patient comes in with an elevated serum lactate, you absolutely have to look at the lactate to pyruvate ratio. An elevated ratio, meaning anything greater than 20 to 25, points directly to a mitochondrial respiratory chain defect. However, if the absolute lactate is high, but the ratio itself is normal or even low, well, that points you toward pyruvate dehydrogenase, or PDH, deficiency. Why? Because in that scenario, the pyruvate is backing up proportionally as well. Here's a pro tip for you, and examiners absolutely love testing this pitfall. Mutant mitochondrial DNA heteroplasmy levels actually decline with age in rapidly dividing mitotic blood leukocytes. But, and this is key, they remain super high in post-mitotic muscle tissue. So if you just rely on a standard blood-based genetic test, it might come back giving you falsely reassuring results. You have to remember, the definitive diagnosis happens in the muscle. Right, let's jump to Section 3, the core clinical syndromes. Now we're zooming out to the whole patient to clearly differentiate the distinct named syndromes using their unique clinical features so you literally never mix them up again. Take MELAS and MRF. Differentiating the MTL1 mutation of MELAS from the MTTK mutation of MRF often hinges entirely on their neurological presentation. MELAS gives you recurrent stroke-like episodes, seizures, and lactic acidosis. MRF, on the flip side, presents with myoclonic epilepsy, ataxia, and those ragged red fibers on biopsy. If you can separate the stroke-like episodes from the myoclonic epilepsy, boom, you instantly have your diagnosis. And speaking of MELAS, here is another massive exam trap you've got to watch out for. MELAS, stroke-like lesions, absolutely do not respect vascular territories. Plus, they can actually shift locations on serial imaging. So, if you're looking at a young patient with lactic acidosis, a maternal family history, and brain lesions that just cross right over those typical vascular boundaries, that should immediately redirect your brain away from a primary cerebrovascular ischemic stroke.
Then we have Kearns-Sayre syndrome, or KSS for short. KSS is defined by a very strict classic triad: onset before age 20, chronic progressive external ophthalmoplegia, and pigmentary retinopathy. And crucially, this is often accompanied by really high-risk cardiac issues, most notably complete heart block. This presentation is highly distinct from other conditions, like NARP, for instance, which features neuropathy and retinitis pigmentosa, or Lee's syndrome, which is an infantile encephalomyelopathy with bilateral basal ganglia lesions. KSS definitely stands in a league of its own here.
Okay, moving into Section 4, Management and Pharmacology Traps. So while the management for primary mitochondrial myopathies is largely supportive, there are some high-stakes pharmacological rules you absolutely must know. Because we don't really have curative therapies yet, we lean on specific supplements, things like coenzyme Q10, L-carnitine, and riboflavin, to really support that mitochondrial biogenesis. We might even use intravenous L-arginine to help with vasodilation during those acute MELAS stroke-like episodes. And vitally, we must aggressively monitor our KSS patients and use prophylactic cardiac pacing. Why? To prevent sudden complete heart block.
Now pay close attention to this one. Never, ever choose sodium valproate for seizure management in a patient with suspected mitochondrial disease. Honestly, this is a fatal trap. Especially when we are talking about POLG-related disorders, valproate can precipitate fulminant hepatic failure. It rapidly accelerates their neurological deterioration. Just don't do it. If you need to manage seizures in these vignettes, look for a safer alternative, something like levetiracetam instead. Finally, we've reached Section 5, High-Yield Exam Takeaways. Let's lock in everything we've learned in this explainer today with the ultimate comparative cheat sheet and then a rapid-fire drill to test your reflexes. Seriously, take a mental snapshot of this matrix right now. Anchoring your revision around these specific name syndrome discriminators will help you resolve the overwhelming majority of examination vignettes. Look closely at the inheritance column. It's mostly maternal, right? But remember, KSS is usually sporadic, and Lee's syndrome is super variable, often nuclear. You need to know these hallmark features absolutely cold.
All right, let's put you to the test. A 16-year-old boy with zero family history presents with ptosis, pigmentary retinopathy, and complete heart block. Think about it for a second. What does a sporadic presentation with this very specific triad and a severe cardiac conduction defect indicate? Do you have it?
The answer is Kearns-Sayre syndrome, and this brilliantly illustrates exactly why recognizing the de novo sporadic nature of a large mitochondrial DNA deletion in KSS, rather than always blindly looking for a maternal family history, is so critical for the exam. I mean, the onset under 20, the eye findings, the heart block, it's just a textbook presentation.
Moving to our final drill question, how do we interpret these exact neurological symptoms, specifically myoclonic epilepsy and ataxia, when they are combined with those classic ragged red fibers on a muscle biopsy? Which specific mutation are we looking at here?
And the answer is the M844A mutation in the MTK gene, which of course gives us MRF. Having that myoclonic epilepsy paired with ragged red fibers points you directly to MRF. And that contrasts perfectly with the stroke-like episodes that would normally point you right to MELAS. As we wrap up this explainer today, I want you to ask yourself, how does mastering these underlying genetic and biochemical rules actually transform your approach? You see, you aren't just memorizing random facts anymore. You're applying true clinical reasoning to things like heteroplasmy, threshold effects, and histology. Keep these logical pillars firmly in mind, and you are going to be able to decode literally any complex metabolic vignette that comes your way. So, how will you apply this logic to the next patient you encounter? Think on that, keep studying hard, and we'll see you in the next one.